All right. Good morning, and thank you for attending our Grand Rounds lecture. I'm pleased to introduce to you our speaker, Dr. Vanessa B. Sheppard. Dr. Sheppard received her doctoral degree in health services from Old Dominion University and completed postdoctoral fellowships at both EVMS and the Moffitt Cancer Center. She has since gone on to become a nationally recognized leader in the field of healthcare disparities, and today she will be sharing her expertise regarding cardiovascular disparities and breast cancer survivors. Here at VCU, she serves as the chair of the Department of Health Behavior and Policy and as the Associate Center Director for Community Outreach, Engagement, and Health Disparities. Dr. Sheppard runs a fully funded lab that focuses on improving breast cancer outcomes for women from racial and ethnic minority backgrounds. She has received several awards for her work, including the Torchbearer Award from the African Women's Cancer Awareness Association, the VCU Women in Science, Dentistry, and Medicine Professional Achievement Award, and the Aretha Health Innovation Award from the AWBC. Throughout her outstanding career, she has maintained a close connection with community organizations, and we are grateful for the positive impact that she has had not only here at VCU, but also in the greater Richmond community. Dr. Sheppard, we look forward to learning from you. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds presentation. To claim credit for today's session, text the code shown at the beginning and end of the presentation to 804-625-4041. I will now turn it over to Dr. Sheppard.
So good morning, everyone. I appreciate the opportunity to be here today and to really share some of the things that we're learning and we're thinking about in terms of addressing disparities. As a disclaimer, so my focus is in breast cancer research and specifically examining aspects of cancer care delivery that we can improve or augment to improve outcomes and or designing interventions, usually behavioral interventions focused at patients, but potentially also interventions at a system level that, again, we can improve outcomes. So that's my interest. Quite honestly, in focusing on disparities, I've been interested throughout my career in anything that could perhaps improve outcomes, specifically for African American women. And so today we'll talk some about what's the rationale for addressing cardiovascular health in cancer survivors, review briefly some of the disparities that we see in regard to cardiovascular disease in survivors, and then maybe talk about some potential interventions. So in terms of definitions that and words that you may hear me talk about, when we think about health equity, I don't regard health equity to be interchangeable necessarily with health disparities. I think health equity is our aspirational goal that we want for everyone to be able to have the highest level of health. At times, I think it's necessary to focus on studies that are more minority health focused studies, and these would be studies that may specifically focus on a racial, ethnic, or minority group or specific attributes of a subpopulation. And so typically in these studies, you may not be doing comparisons, but specifically focus on one group. And then health disparities then would be the differences in health outcomes that are linked to multi-level factors such as social, economic, and environmental disadvantage that we know are driven largely by social conditions. And then my work has tended to focus a lot in cancer health disparities, which again is sort of comparing various cancer metrics between groups. Often there are racial ethnic comparisons, but you could also look at disparities related to gender, where one lives, and some other characteristics. So when we think about the burden of disease in adult cancer survivors, we need to focus on this population because given the improvements in treatment, early detection, we've seen an improvement in overall survival with over 17 million cancer survivors. The majority of these survivors, we're expecting to live beyond 5 years and to be many of them cured from their cancer. And however, with survivors now living longer, there's more attention to many of the latent effects that can occur, and specifically around cardiovascular disease. And so survivors over 50, among men, about over 50% for men and about 40% of women can expect to develop cardiovascular diseases. And this would seem to be, of course, we need to focus on this population. Of course, we need to think about cardiovascular disease. But what I can tell you Until the focus really on cancer survivorship, there have been these distinct silos. And so people that focus in cancer research focus in cancer. I remember asking a question it's a long time ago when I was a postdoc about comorbidities and other diseases, and literally was told by experts at the time that has nothing to do with cancer. And I'm not that old, and we can see that there's been this sort of transition. When we think about childhood cancer survivors, similarly, the majority of children and adolescents that are diagnosed with cancer, they'll be long-term survivors. And we have a large number of pediatric cancer survivors in the United States. Unfortunately, when we consider the rate of cardiac mortality in these survivors compared to children that were not diagnosed with cancer, it's over sevenfold. And so over a 15-fold lifetime increase of developing heart failure compared to their age-matched population. So we have adults that are surviving cancer that we need to focus on their health, as well as childhood cancer survivors who will grow up, most of them to adulthood. So when we think about cardiotoxicities, a lot of research has really focused on anthracycline-based therapies. However, those are not the only culprits that we're concerned about when we think about therapies that are toxic. What we can see and what we know is that across the spectrum from chemotherapy, even immunotherapies, that there are potential assaults to the heart. So a lot of the research that has been done has tended to focus a little bit more on breast cancer when we think about toxicities, and many more focused on anthracycline therapy. Recent data has led us to also focus on women that may be receiving adjuvant endocrine therapy treatments, which we know also increase the risk for cardiotoxicity. So when we think about data that's available, there's not a lot of population-based data. When you really want to examine, what are the rates of cardiovascular disease and cardiotoxicity in the population? And there have been very few reports. And so this is a population-based study that's using SEER data. And so SEER, those are the state cancer registries. Unfortunately, Virginia is not a part of SEER. But this allows examination of sort of population-based data. And so what we know is, when you consider both the risk of dying from cancer and then the risk of heart disease, is that the majority of deaths from cardiovascular disease tend to come from patients diagnosed with the more common cancers, such as breast and prostate, but also bladder cancer. But when we look at overall from diagnosis forward, that there is an increase for all sites, elevated risk of dying for cardiovascular disease compared to the general population. Some other data that's from the National Health Nutrition Examination Survey or from some colleagues at Ohio State, where they analyzed these data and found, and this is comparing individuals without cancer with a positive cancer diagnosis. Now, what they typically don't have often is good necessarily treatment data or data from detailed data from clinopathological data. But we do see this increased risk, and particularly among certain age groups. Interestingly, in African Americans, we see a higher risk of mortality under the age of 69. So overall, what we know is in the general population, that Black adults are 32% more likely to die from cardiovascular disease. And so that would have us necessarily thinking about once individuals are diagnosed with cancer, the risk factors that they had that would make them at risk for dying from cardiovascular disease would still be present at the cancer diagnosis. So that's exacerbated. So some of the factors that we know when we think about then addressing disparities, yes, we focus on the diagnosis at hand, but what are some other things that may be going on in this population? And so here we see the higher rates of hypertension, diabetes, and stroke when we compare African Americans to non-whites, to non-Hispanic whites. And then also looking at social indicators. And so these social indicators are important because when we talk about issues of health equity and disparities, these are the underlying factors and the structural factors that we know that contribute to one's opportunity to be healthy. And so when we compare whites to Blacks, we see differences in higher rates of unemployment, a higher likelihood of living in poverty, um, limited home ownership, and these factors sort of give us an indication of to one's social capital or wealth. And then importantly, looking at and examining whether or not a person could see a physician because of cost. So when we think about the prevention aspect, before people are diagnosed with cancer, and even perhaps before diagnosed with cardiovascular disease, or how they're managing their disease, we see that there are barriers to care. And particularly concerning are levels of inactivity and rates of obesity that we see in the population. So we think about breast cancer, as I mentioned before, a lot of the research has tended to focus on breast cancer, particularly around anthracycline therapy. Breast cancer is the leading cancer diagnosed in women, and women, the second cause of death in women is cardiovascular disease. And so these two things go together. And what's particularly interesting that needs more work is a lot of these cardiovascular events occur 5 to 8 years after diagnosis. And we really don't have very good distinguishing factors to know and necessarily in predicting models in terms of who's more likely and controlling for why the persistent racial disparity. When we think about African American women, overall, African American women have a 40% higher mortality of dying from breast cancer. So we have these two competing factors that we care about in the African American community. This chart just depicts sort of the mortality rates over time, and what we see is, and these data are coming from the SEER national data, is that as we begin to collect data, it appears as if white women had a higher mortality, but what you clearly see over time is this lowering mortality from breast cancer, rising for African American women, declining, but not at the same rate, and you see this gap in survival. And so what we know is that we became better at early detection. We had the advent of systemic therapies. And so some of these data suggest that, well, this isn't necessarily a biological factor. I mean, truly, we've been able to categorize the subtypes of breast cancer much better, but it's the treatment. Are we disseminating the treatments appropriately? Do individuals have access to the treatments? And then perhaps when we are designing clinical trials and targeted therapies, are those therapies benefiting populations that have disproportionate types and subtypes of breast cancer? And so this gets back to as we think about inclusion in clinical trials. So some of the disparities in cardio oncology overall, patients from historically marginalized racial ethnic groups have higher incidence of cardiotoxicity. Black patients versus non-Blacks have been found to have a threefold higher risk of cardiotoxicity. Trastuzumab and other HER2 targeted therapies, we see that about 17% of patients would experience cardiotoxicity, and that in a study that controlled for um, um, comorbidities at diagnosis, still found that Black women were twice as likely to develop cardiotoxicity than their white patients. And there really isn't quite a good explanation for understanding that. And other data suggests that there are increased rates of adverse cardiovascular outcomes in Black patients, and that Black women with breast cancer may be 25% more likely at greater risk of cardiovascular death. So when we talk about a population that's already dealing with higher mortality, and then to survive breast cancer, to then have this competing mortality, that's of concern. So this is a review that was done by a trainee at both Dr. Helling and mine, Dr. Sutton, who wanted to do a review to look at studies that reported cardiovascular toxicity by race, and then look at studies that explored what factors may contribute to those racial differences. And some of this, one of the studies that's been referenced earlier, that's from SEER Medicaid data. Most of the studies, all of them in fact, were retrospective. So then that gives us an indication that we're really missing data from prospective studies. We're excited about Upbeat that Dr. Hunley is leading to a national study that's going to really help to fill these gaps. These studies focused on all types of cancer therapies and had various measures of cardiotoxicity. Overall, Black women had this, were twice as likely to have cardiotoxicities compared to white women. but none of the studies were able to identify factors that help to explain these differences. And so this leads us to think about unmeasured factors, structural factors that may come into play that we often don't have. So structural racism, we hear a lot of talk about racism these days and social justice, just given the era that we're in. We know contributes to disparities in cardio oncology. Quite often, it's not something that we feel like we can measure, and unfortunately, sometimes not something we feel like we can do something about. But these underlying factors that give a propensity for one group to have higher rates of risk factors, where they live, where access to care and prevention and behavioral factors. Then there's the underrepresentation in research that just occurs. When you look at studies, you'll find that in cancer studies specifically, there's very low representation of minorities in clinical trials. Even some of the clinical trials regarding breast cancer, there have been landmark trials. There hasn't been proportional representation in many of them. Socioeconomic and cultural barriers, and sometimes people may focus on things such as, mistrust or distrust of the institution. And some of the recent articles that are doing a call to action around cardio-oncology disparities, have talked about this distrust. But I think when we think about issues of trust, we also have to think about what happens within our healthcare system that may lead to that. And then the lack of access to specialty care. So when we think about Virginia as an interesting place, I think, to focus on disparities, and an interesting place to also sort of think about this longitudinal effect that we've had. And so in, some years ago, 2019, there were celebrations in the Hampton area acknowledging sort of the birth of African America, when which is symbolic of the 20 or so Africans that sort of landed in what was the New World. And so what you see is a series of laws that were specifically actually targeted towards African American women in terms of control over their bodies and, the type of work that was done, lasting for generations. Recent data even suggests that the poor outcomes for breast cancer and some associations between individuals that grew up doing Jim Crow and are showing worse outcomes. And Virginia has is acknowledged as having several hotspots for cancer. For breast cancer is one, and one of these hotspots in the country, prostate cancer and colorectal cancer. And so we see differences based on where generations of people have lived in terms of the outcomes that individuals face in our state in particular. So when we think about Black women, what does childbirth have to do with cancer or cardiovascular disease? So you think about actually the sort of first experiences with adult care. Quite often for women in general, it's going to a gynecologist. And so these were some of the headlines of, celebrities that almost died during childbirth, and really brings the attention to a signal in our healthcare system. Our healthcare system quality is judged in part by, do mothers and children, do they have an equal right to live? So we look at some of this quick statistics for Virginia, just to give a taste in terms of our the population. We see that we have about 10%, of the population. Let's see here. There we go. Is looking at African Americans, about 50% though of all women. In what we call our catchment area, we actually have about 40% of African Americans. So thinking about the people that we tend to serve in VCU Health, we see a large percentage of African Americans, and differences in terms of age, marital status, and again, these sort of social factors that may impact one's outcomes. There we go. We see differences in life expectancy at the national level, but also in our state as well. And some would say, well, that's not many years of life difference, but I think every year of life counts. And then we see these sort of really horrific rates of maternal mortality. both nationally and also in our state. And so again, we're thinking about people's experiences with the healthcare system and how does that layer in terms of one's opportunity to practice some of the health behaviors that we talk about. So higher rates of obesity and lower rates of depression. And so this is a common theme that we tend to see in data, even among African American and white breast cancer survivors. We may see poorer physical ratings of health among Black women compared to whites, but we often see higher ratings of mental health. And so that gives us something to think about in terms of our interventions. And so this is a schematic that was in one of the article that I sent. And what I like from this literature review is that it's an attempt to summarize these multi-level factors that we know influence disparities. And so the example here, what we see are these sort of structural factors. We think about racism and sexism. So these are aspects of the intersectionality of being a woman and being a woman of color. We think about our economic and public and sort of social policies, wealth distribution, and governance. And so these are things that are often outside of the control of healthcare providers. But these are things that we should keep in mind when we make a prescription, when we make a referral. Does the individual have that ability? But these factors we know are underlying structural factors that they do impact and increase rates of cardiovascular risk factors among Black and other individuals of color. We know that these structural factors also would impact advanced stage and delayed cancer diagnosis. And so that delay in cancer diagnosis, from the data that we've collected, we've seen it maybe delay based on the patient and also delay based on the healthcare system. Unfortunately, we, while studying, looking at uptake of treatment and treatment adherence, we often uncover other factors. And so where women maybe they went and presented with problems and were told you're too young for breast cancer, or of a case of one of our study participants who was being treated for an ulcer, but was actually experiencing heart failure. And just wondering how the system failed her. She ended up surviving surgery and then had a relapse and then really had to choose between, do I die from heart failure or do I die from the cardiotoxicity of treatment? And in the end, the decision was made to stop her treatment. And so she died from heart failure. But again, for weeks had been going to the doctor and complaining of symptoms. Black patients have this overall higher rate of death from cancer. And then in addition, across stage, lower stage specific survival. So then we think about, well, how do these factors sort of come into play here? This is often where we think about, well, we have some opportunities to intervene. And so it's maybe these baseline health risk factors that we know differ between Blacks and whites. Do we offer different treatments based on these baseline risk factors? For the most part, not so much. For many people, they are being treated by their oncologist for cancer, and then also may or may not still see their primary care physician. And again, some of this relates to if you had an ongoing relationship with your primary care physician at diagnosis, and not everyone did. And so then we think about this whole treatment trajectory in terms of the opportunities then to have cardioprotective strategies here. And this relates back to how we are organizing our system of care and the crosstalk that happens across care. And then here, some of these factors, again, are these sort of social structural factors that we think about. And, just using transportation as an example, if there are individuals that have trouble getting to their chemotherapy appointments because of transportation, how likely then are they going to be able to make it to referrals across tail? And so again, some of the things that we have to think about that in the long term impacts the outcomes that we see, disparate outcomes. Some of the things I think we can do, and we'll talk a little bit more about that too, is address these clinical inequities. And so there's access to cardio-oncology care. So access to all, so we can think about, do we really have access to all individuals diagnosed with cancer early on? There's cardioprotective treatment. training and provider implicit bias. And regardless of what the provider looks like, we all have biases that we should address. And then really this idea of representation in clinical trials, which I'll talk a little bit more. So we think about some factors such as perceived cancer care discrimination. We just examine the rate of reported cancer care discrimination in survivors. And so the first study was in over 300 survivors, and we saw 30% of Black women reported discrimination. And one's race, and then trust in the oncologist was associated with discrimination. So again, that relationship that a patient has with her oncologist is really critical. And we found that to be consistent in studies in terms of provision of a biospecimen. Patients that had high trust in their providers participated in trials, even though their physician was not a part of the trial. So this relationship, trust in one's provider, diminished delay and to surgery for breast cancer survivors is important. In another study, and these analyses are ongoing, and 900 survivors, about 20% overall reported discrimination, and most white Black women, 40% rather, reported discrimination, and 7% of whites. And the dimensions that people tended to regard discrimination, they really relate to the interaction that they have with the staff in terms of the perceptions of discrimination. When we examine, well, okay, there are differences between Black and whites in discrimination experiences. No surprise there. Well, what are some of the factors that may explain it? Is it age? Is it your marital status? Is it what you sort of believe about the healthcare system? So we found that about 46% of all these variables that we examined explained the differences in discrimination. And so that also suggests that there are a lot of these structural factors that are typically unmeasured that may explain some of these differences in care. So some of the missed opportunities I think that we have had to consider issues that relate to the heart are studies where we have recruited a decent number of African Americans. And so this particular study, over 51% were African American. So this was a study where we actually recruited more Blacks than whites. And we did capture data on comorbidities, and that was just to be able to describe our patient population. We found that patients with more comorbidities tended to also have more treatment modalities. And so basically comparing women who didn't have comorbidities, the women who did have comorbidities tended to need chemotherapy, to have radiation, and adjuvant endocrine therapy. So suggesting that the people with the comorbidities, that diagnosis, are also having more aggressive diagnoses from cancer and having more treatment, which again makes us more concerned about their heart. There was a lack of long-term follow-up in these patients, and there was very limited knowledge about the non-cancer risk. And so I call this was one of our missed opportunities because this was a missed opportunity for us to sort of think about how are we partnering. And so quite often, even when we're doing our research, the research is occurring in silos. So my interest was in cancer care delivery. My interest was in adherence and treatment. And how much more powerful could it have been had we, in this recruitment, worked with other types of researchers. So in a study that we actually recruited over 500 participants, and these were all women who are HR positive. We began to be interested. Again, this was a study primarily focused on cancer care delivery, adherence to adjuvant endocrine therapy. But as we became apprised of other data suggesting that there may be some issues related to cardiotoxicity in this population, we began to sort of examine, well, what's the cardioprotective medication use in this population? And so this study examined the prevalence of cardioprotective medication use in survivors, and then to identify factors that may have been associated with race. And we included all women who were in what's referred to as a WIP study who had complete pharmacy records. And so this focused on 246 women, 33% were Black, and overall, you see the majority had hypertension. And about a third we saw were receiving these medications. Hypertension status was a key predictor in terms of receipt of cardioprotective medications, and among Black women, age was a significant factor. As we think about this, we could expect that the rate could be higher among African Americans. And there is some concern that the typical medication that an African American woman may be prescribed is not cardioprotective for her. And so, thinking about again, what's the crosstalk between the medical oncologist, um, are women seeing cardiologists while they're in treatment, and what's the relationship with their primary care provider? And so these opportunities to really think about how we are perhaps even women are set up, not because of their own behavior, not because of fault of the system, just because different types of medications are prescribed to manage hypertension may then put African American women at a disadvantage. So when we were conducting some of these observational cohort studies, we began to notice that higher rates of comorbidities, as I mentioned, higher rates of obesity, and qualitative data from survivors also indicated that that wasn't something that was talked about in their interactions receiving their care for cancer. And so at survivorship, it's like, you made it, you're done, woohoo, this is great. And women really necessarily weren't focused on lifestyle interventions. And so that's what actually informed our decision to develop a lifestyle intervention. This is two-arm pilot study funded by NCI, 12-week intervention. We didn't quite hit our weight loss goal. Women in the study received tailored group-based classes about to exercise, and also dietary advice in terms of to lose weight. What we did see, though, was increase in total levels of physical activity in the intervention group. This didn't occur in the control group. And we did see movement and improvement in cardiorespiratory fitness. In the control group, it appeared to be a decline, but it could be because of the sample size. What was interesting to us is that, again, we weren't focused on heart health. So here we are, collecting these measures focused on weight loss, focused on, physical activity, all very good things. But we feel like we have to start to think more holistically. Like, if we have an opportunity to touch an African American woman that may be at risk of cardiovascular mortality and a breast cancer recurrence, we should be thinking about having interventions that are a little bit more comprehensive, right? Now, that may not go as well with the funding source, but I think we have to think about how do we fill the gap between the real life that people are experiencing and our funding sources. So low knowledge about heart health and looking at some of the rates of cardiorespiratory levels of fitness, it really wasn't even until here that we did the pilot that one of our colleagues, Dr. Lee Franco, sort of pointed out that, oh my goodness, these women that are coming in to exercise, they're having like heart failure. Like, they're coming in to exercise and no one's told them, and they're out amongst us. So, clearly we have opportunities to try to make the mark a little bit better. So some suggested approaches is this whole issue of, science discovery, dismantling racism, community engagement. And so we are adapting some of these from Faisal et al. The one is incorporate data from diverse populations. So even in preclinical studies. So to do that, we have to be intentional, right? And so we have to think about not just where we work. Fortunately, at VCU, we have a diverse population, but a lot of great studies are being done at places that they don't have a diverse population. And so one suggestion that we have is then partner with people who do, right? Consider race as a social construct. And so again, when we think about race, it's self-reported race. Race is a social marker of a compilation of other factors of an experience a group may have had versus this biological factor. When we think something is biological, sometimes we don't think we can do much about it, but we know race is not a biological factor, particularly when we're measuring it as self-report. Dismantling racism. So, their language was to enforce minimum participation for historically marginalized group. I'm not sure how we can enforce that. I think to enforce it would really require this multi-level approach. So reviewers, when they're reviewing protocols and on study section, looking at the diversity that's expected, and even when we develop trials that by independent investigator-initiated trials, thinking about that as well. And then, of course, always reporting demographics. So when we were going and looking at some of these studies and reviewing them, not all the studies report information based on race. So you're actually peeling through the article, and it's not very helpful to do that. Issues related to workforce, I think, is important. Um, and to me, that relates to how can we all participate in that? Well, who are we having on our teams, right? And having diverse individuals on our research teams in our clinics, and also thinking about ongoing training. In terms of community engagement, I think we have opportunities to provide care in multiple places. One of the things I can say from working here at BCU, I think that we have lots of great things happening in the community. I would love to see some of that be coordinated across entities. What we often see is, I may show up with my cancer hat on, someone else is showing up with their diabetes hat on, and so we can often overburden the community in one place. So how are we working together and really partnering to erase information, disseminate and raise awareness about disparities? And then, of course, just access to cardio oncology. That's a terminology that sort of rolls off of our tongues. It is not so widely known in the community. So I think, again, we have these opportunities. So just thinking about engaging Black women in research, very quickly, I'll just talk about being very intentional. And so what we found in some of our work with recruiting Latinas and African-American women is that this sort of approach that we've taken has enabled us to recruit large numbers of diverse women to mostly observational studies, but also to behavioral intervention research. And so this relates to our teams. And so the teams that are definitely interdisciplinary, and we want to even do better there. Teams that have diverse individuals on them that represent ideally the groups that we're prioritizing in our work. Thinking about then how we use culturally relevant approaches in terms of recruitment, in terms of our materials, and in terms of our delivery. And I would say, even if it's a therapeutic trial, we have opportunities to think about culturally relevant approaches to the delivery of that intervention. The research staff, who will the research participants see and hear from first? And having diverse individuals who have taken time to acknowledge the place where they are, where their patients and research participants are coming from is very important. We have found it beneficial in places to have a spokesperson from the community. And sometimes that spokesperson has been someone from the radio. Sometimes it's been someone from the local housing authority where individuals lived, and sometimes it's been a person from the church. And then quite simply, how are we tailoring our methods and materials? And this is where we're actually challenging ourselves to be a little bit better with the use of technology, and then also balancing that when sometimes the simplest way of communication is also important. So expanding access to trials, we'd say no more excuses that minorities don't live here, and develop a diversity plan. So if we're going to conduct a study, what's the diversity plan? That needs to be something that we do automatically, that we're thinking about it. If we're not thinking about it up front, chances to say we're not going to think about it later. How we power our studies is going to be important. Sometimes, we just want to add some diversity in who's there, but then it doesn't set us up to be able to conduct stratified analyses. And so we should think about that upfront with our research in terms of maybe powering them differently. I've already talked about our teams and the expertise. Someone shared an article with me recently in terms of how health equity and disparities research is being colonized by white researchers who've never delved in the space. And so, I think that that's concerning. They pointed out recently in JAMA, focused on, so people are getting the disparities train, so to speak, and didn't have research from investigators of color. So I think it's important to think about our teams and the expertise and to acknowledge, just as I am not a cardiologist, but if I want that view, then I need to reach out and have that expertise so I can be sure that I'm being thoughtful about my work. And then communication with community stakeholders. So in terms of strategies, there really aren't optimal strategies for preventing and managing cardiotoxicity. We think exercise could be an approach. And of course, there are different drugs and that can be useful, but we also think that exercise could be one. And so we're starting to actually explore that. We found that individuals who have more knowledge about heart disease and education, then they had better metrics, and because that probably means that they're more aware, that they're monitoring. And then lifestyle interventions, including healthy diet, physical activity, should be really integrated into a survivorship care plan. And we know that survivorship care plans are expected, but we also know that they're delivered in various ways and oftentimes may not be followed up on after they're disseminated. So that's some opportunities I think that we have. So why am I excited right now? Well, I'm excited even though I haven't had tea or coffee this morning because I'm working with a team of investigators on cardio-oncology breast cancer disparities. And what I think is so exciting is that the opportunity to fill gaps in what we know and what we don't know from the basic cellular pathways to epi studies to our clinical intervention that I'll talk very briefly about, and also with the emphasis on disparities, having a community core. So as I work towards sort of wrapping up, I'll just talk very briefly in terms of what we're thinking about where we may have an opportunity to make a difference. So when we think about these cardiovascular risk factors at diagnosis, and you've heard me talk about them. Haven't talked so much about the social stress piece, but the issues sort of related to that social structural factors that many African Americans particularly have to endure kind of leads to social stress. And the perceived discrimination and some of these other factors that we can have an opportunity to actually measure using allostatic load. And so these sort of risk factors at diagnosis, then you get the cancer diagnosis. And some of these things may or obviously if people are experiencing some of these things, they may or may not be managed very well. Then you have the diagnosis of cancer, then you have treatment. And so this sort of idea of this multiple hit hypothesis of things that are causing injury and insult to the body can influence these factors here, such as exercise intolerance, systemic inflammation, cardiotoxicity, worse quality of life, and psychosocial distress. So all of these factors can relate to sort of these pre-existing conditions. And then from the treatment, what our question is, can we have a behavioral exercise intervention that addresses issues of psychosocial education and support? Can that perhaps blunt some of the factors for women during treatment? And there have been, again, quite a few studies focused on breast cancer, not as many actually that we find have focused on African Americans, very few interventions, and virtually none during treatment. And so this is some of the preliminary data that led us part of the rationale to focus on African American women. And so with this study, we plan to recruit 150 newly diagnosed Black and white women. And rather than test the intervention approach, we're building on sort of the state of the art intervention approaches. And we want to identify the physiological mechanisms of action of this tailored exercise intervention. And so what we recognize is during treatment that women can experience fatigue during chemotherapy specifically. And so having the intervention to be tailored when women may feel better or worse, the idea is to keep them exercising throughout and to be able to understand then what are these mechanisms that will impact their exercise intolerance and LVF. The second aim is then to look at the psychological and behavioral mechanisms. And so the factors that we talked about related to, so the behavior that will be important in the two arms that we'll have will be the intervention arm and then this health education control arm. And then lastly, to explore the treatment-related factors and then also the social structural factors that may moderate the effects of the tailored exercise intervention. And to our knowledge, we're not aware of a study that has focused on trying to reduce the disparities upfront that Black women may experience during treatment, and also then to explore these other factors that we know are important. And so I present a lot of data about disparities, and it's not all bad news. What we know is that Black women are surviving cancer at better rates, and we also know that African American women, despite the fact of dealing with multiple overlapping oppressions, have lower rates of suicide compared to their white counterparts. We know that Black women have coping strategies for both racial and gender bias that's resulted in different techniques, such as standing on shoulders, valuing oneself, leaning on shoulders, and resting on faith. And so the thought is, how are we also making sure that we measure factors of resilience, that we measure factors of positive coping, and just as importantly, how we are integrating these components into our trial. We also find that about 27% more African Americans compared to whites are free of mental disorders. And so when we think about some of the factors that there are, despite the disparities, we see that African American women have positive outcomes, particularly with regard to mental health and generally lower rates of smoking compared to whites. So one of the things I mentioned earlier is that we will have a community engagement core that'll be a part of these trials, part of this program project. And we want to have these capacity building strategies since we've noted that there's a lack of education about cardio oncology, gives us an opportunity to educate the community, the large community of survivors that are there. So real quickly, we're going to establish a community advisory board, which we've done. And this board is not just going to be on the peripheral, but this board is going to be integrated to, yes, help us increase community awareness, but also to guide and provide feedback to the research team. And we plan to, we think, innovatively establish community research teams. And so having community members who are going to serve as consultants on each research project. And what I can say is I'm very honored to work with colleagues who have been so receptive and open to this type of engagement, which is, again, I think is going to be a very important factor moving forward. And then to have this bidirectional community engagement that's focused on this capacity building with our team in terms of workshops to build capacity and also for us to learn more. And we are planning to have a very synergistic core that worked with the research team and the other cores with regard to projects. And so the initial response from some of our community members was that they joined us in a retreat and they were struck by we need to explore opportunities to present findings in a more positive way. And it caused me to pause for a moment because at the end of the day, we're all scientists and we think about their rationale, their problems. And the community members like, oh my goodness, cancer can come back and be worse, but now there's information about the heart, now how are we going to limit survivor worry? So on balance, how are we going to educate survivors? Also, how are we going to make sure that we don't have unnecessary worry? Our community individuals also reviewed the specific aims and plans and appreciated, gave us some feedback around simplifying our messaging and community action. And so while reading statistics was difficult, they appreciated and they felt like the group did a good job of simplifying these things and just sort of thinking about that. They also felt that, interestingly, and so there was some concern about the use of mice to represent Black cancer survivors. And again, sometimes we don't even think about these things as researchers until we present things to a community member. What we know moving forward is that most agencies are starting to incorporate community stakeholder review. And so this just gives us something to think about because we recognize, and it's a benefit, in fact, that we can do certain experiments in mice that we can't do in humans, right? We can control for certain things. But thinking about our language and how we communicate that as a team, I thought was interesting in terms of a thought. And then lastly, there were some suggestions for action because community members appreciate the research, but at the end of the day, it takes so long to get our findings. So like, what can we do right now? And so they talked about really maybe having caseworkers to sign to help assigned to patients to help them get a plan based on their resources, and then just talked about some of the issues that people may have based on where they live. So we could see perhaps thinking about things in the future, such as navigation, that may be appropriate post-treatment for individuals. And so in ending, just some of the work that's ongoing that we are working in collaboration with a trainee is looking at associations of factors related to cardiotoxicity in our own patient population here at VCU. So we're looking forward to receiving that information. So take home messages. There are gaps in science regarding cardio-oncology disparities. Quite honestly, there are more gaps than knowledge when it comes to really looking at issues of disparities, even among the most studied group of survivors. So even among breast cancer patients, there's a lot that we don't understand, a lot that we don't know. Including diverse scientists and community stakeholders in research, I think is one way that we can proactively address issues of disparities. We need trials with diverse patients and survivor samples, and it takes time and thought to get there. Team science approaches are needed. Some of the missed opportunities I feel like we had early on was we could have more easily collected tissue. We could have more easily had MRIs. The patients were right there at our cancer center. And then just better coordinated care for all can impact disparities. And so this is the code I'm supposed to show at the end. And I'll leave it here for a few minutes and can stop and have questions and discussion.
Dr. Sheppard, thanks so much for that fantastic and important presentation. We'll now open it up to questions, and feel free to...
Yeah, thanks. Vanessa, I just wanted to ask you two questions. One comment you made during your presentation, that Black women might have more obesity, but would have less depression, and that would set up different opportunities for different types of treatment. And I wondered if you could elaborate on that.
So I guess, so I think there were two things that I mentioned. So one, I think the question was, we know that we have differences in these comorbidities, such as obesity, hypertension, and such. And so I'm just wondering, do we do any augmentation of the treatment plan based on any of these factors, right, that we know pre-exist? So we have these pre-existing conditions that the studies retrospectively have controlled for, but we don't know, are there any differences in the delivery of treatment based on any of these factors that could also make one more at risk of cardiotoxicity? So that's just a question. The other comment was in relationship to where we see, the higher prevalence of some of these factors like obesity, worse physical functioning using, the patient-reported outcomes measures. But on those same patient-reported outcome measures, we tend to see higher rates of mental health and lower rates of depression, generally speaking. We are seeing increases in depression, though, in African-American women, particularly younger women. These are some of the trends that are happening. But with that, does that give us an opportunity to think about our interventions differently, right? In terms of where we see factors that may be protective, to understand that, right? Particularly when you have two groups of individuals that may, Black and white women that may report, similar occurrences of these life events. I had to move, I had to divorce, all these things, but then not have the clinical depression or the rates of mental health. So what is it there that gives us an opportunity for interventions to maybe be even more powerful?
Very good. And just one quick follow-up question. Do you feel that there could be a shortage of individuals of color involved in research and also delivery of clinical care? And if so, what should we try to do to address that?
So the short answer is yes. I think there is a shortage. And so I think that we need more exposure to careers earlier. I think we need to, from the whole research perspective, right? So from the physicians to the research associates, there are opportunities along the spectrum to have diversity. And so I think that we need more exposure, we need more training programs, and the earlier we start, the better, so that these ideas are already in people's head as an option.
Very nice. Thank you so much for meeting with us today.
You're welcome.
Dr. Sheppard, I also had a quick question. You really nicely outlined the different factors as far as the national data that contributes to some of these healthcare disparities. I was wondering if, in your experience in the Richmond community, if those factors are paralleled in our community. Are there any differences that deserve to be highlighted, and anything that we could maybe do better as clinicians to address anything that might be more Richmond specific?
Sure. So I think what's interesting within Richmond, we have multiple Richmonds, right? And so we know that there are life expectancy differences in life expectancy depending on where you live in Richmond that are quite notable, that are important. And particularly, the East End, although the East End is changing a lot in Richmond versus some other parts of Richmond. And so what's different, right? It's like, well, there are areas that didn't have a grocery store in Richmond. And so some of the things I think we can always be advocates for looking around us just as members of the community. And then I think in certain areas, when we think about our again, our catchment area, there are some areas that have more problems with transportation and housing than other areas. We have rural communities that aren't too far from here that come to VCU for care. And I probably shouldn't say this, but I'd never really thought about, the lack of fresh food being an issue in rural areas, really until I moved here and saw firsthand. So I think in terms of connections with some of the social agencies that we have and being aware of those is helpful. I think that our health system is thinking more about the social determinants of health anyway. And so I think just, being aware of that is important. And then recognizing that, Richmond, I'd say I've seen more issues with transportation than I saw when I lived in Washington, DC, just based on the availability of public transportation.
Thank you. I believe Dr. Weezar from the VA might have a question.
Yes, good morning. Dr. Sheppard, thank you. It was a very good and interesting presentation. Something that I struggle with, and I want to see your take, and maybe this is something we need to, maybe the resources are there, and I'm maybe partly ignorant on this, but some of the aspects that I frequently find is that I'm trying to send a grant application for research, and I'm trying to see how can I diversify really try to include different races and ethnicities on my project, and I end up usually going down to the path, okay, well, I have these many ablations, this is how many were different races and ethnicities, and with that I present this, and I said, well, I'm going to try to make the best effort to recruit these population. And I also see this frequently with applications that I'm reviewing from other centers in which they kind of face the same dilemma, I guess, or troubles. And part of the NIH and really all these institutions are really putting a lot of emphasis on making sure that there is an inclusion of diversity. But I struggle with this sense on what really is enough. And sometimes is it providing this data enough, and should we just settle, or should we really expect, and we should really from our side also try to reach more and do more, trying to really include these patients. So sometimes I think that I wrongfully so I settled, and I think this is something that maybe we need to work on. Again, maybe there are resources that I really need to, that I need to reach out. And also when I'm reviewing panels, as a review panel, I really should expect to, in order to really avoid these biases you have said.
I think that's a very good and important point, and it's very real for many people who would like to do better. So, one thought is, and we're thinking about this on the Alliance group for clinical oncology trials, is that should there be targets, right? And so there's some studies would say, or some people, 20%. I think it goes back to what the research question is and who's disproportionately represented, right? And so if we're studying a cancer or condition that we know disproportionately impacts, say, males, then we couldn't suffice to have, a low percentage of males in the study. And so similarly, I think when it got with regard to race and ethnicity, and so to me, then the scientific question is driving the inclusion of diverse groups and also the burden of the condition. Because to me, it could be an elegant study that's wonderful, but if it doesn't include the groups that are most impacted, then it lowers, in my regard, and I think others in terms of the definition of impact, it lowers the scientific impact, right? And it certainly would lower the generalizability. So, I think that going back to, what's the goal of the study? Are groups disproportionately impacted? And then do we need to partner with other places? And so this may again help many of us to get out of our silos to say, maybe we need to partner with another institution that has diverse patients coming in. But it is something I think we have to be very intentional about and really hold ourselves accountable, and then the applications that we review accountable as well with this investment of our tax dollars.
Thank you.
Great. So I think it's just after 8:30, so we'll have to wrap up there. But Dr. Sheppard, thank you so much for this amazing presentation and for spending the morning with us. We very much appreciate it. Just a reminder to text the code at the number below for CME credit. And everyone have a good morning.
Thank you. Bye.